The second letter behind that one is 5 pages long. It's a generic letter, but it lists all of the reasons for denial and this is what the patient would see. Not all of them at once, but the ones that were pertinent to their case. This is what the patient would see. This too is a letter that's generated by our system that we're not allowed to change. Now the forms behind that are posted outside of our office. Information sheets for patients. And that they can pick up there in the office. Councilor Callison, you and I had a conversation last week, and one of the things you brought up was, is there anyone that can help a patient write an appeal? And we've started that conversation. We're looking at incorporating that into the, not the benefit coordinators, the patient advocate. That way, any patient that needs help with an appeal, they have someone they can go to help them write that. We're looking at getting that started. I appreciate that recommendation. Yes.
And on that side, George, when I do discuss this, you know, like I've told you, and I will tell you on the air, you know, you guys do a great job. I'm not going to say that things don't fall between the cracks and we don't have things to fix. One question I'd have that I thought since, and George and I had about an hour-long conversation on the phone. We were, you know, boy, if they'd just listened to us, we'd have everything fixed right off the bat. But the point is, sir, once they're denied, okay, and what do we reach out and treat them? Because I mean, if they've got a bum knee and the knee's not going to be fixed and it's denied, what do? Do they just not keep coming to the doctor? Does the doctor call them back in? And do we have alternate plans to fix this? Because my issue I have with both sides of contract health is that we hire these people, we respect these people's work, or we wouldn't put them in our referral system. So how do we go about treating those folks once they've been denied for what the doctor says they need to have done? Is there anything we can do with that?
Well, they have the appeal process. Say you're sent in for a knee replacement is not a good example. That's going to be denied. We don't provide knee replacements. But the doctor puts in a referral for you and it gets denied. You have 30 days to appeal that. There are 2 levels of appeal. You can appeal it back to us with additional information. And that's where we're looking at adding the patient advocate to help assist write that appeal. And they can also appeal if that's denied. There's a second level of appeal with the area director.
So if it's denied, then it's going to be up to the patient to go back to his doctor that referred him to the other doctor to get any relief from what he's done. Is that kind of, that's kind of where I'm at with it. I just don't know where they go, because once they're denied, they know they're not going to get it. They appeal, they're denied. How do they go to fix the pain or the problem they have after they've been denied?
They would go back to their primary care doctor for care. Now, one of the things in our system, and you may correct me if I'm wrong, Dr. Jones, is after once you're denied, if a Cherokee Nation citizen is denied in our system, then I'm told they are eligible to be considered in the Cherokee Nation system. 2 denials or 3? Two? Okay, then that's even better, because once you get through the first denial and then the second denial, you don't have to go to the area office denial, then that citizen can be considered within Cherokee Nation.
You good, Danny? Still want the floor?
Let me ask you one other question while I'm asking you. What is the average time, let's say you do approve it, okay, and when they go in, and like I said, I've used this most of my life. When you go in to the orthopedic guy, you're going to sign a piece of paper that says you're responsible for these charges if they don't pay. They always make you sign this paper that someone's got to pay. So the point is, how long does it take your office to pay these bills?
We are, normally it doesn't take very long. We're good, within just a month or so. We're, on the federal side, we're fighting we're having issues with our fiscal intermediary, Blue Cross and Blue Shield, and they have been not paying those bills regularly, and we've been reaching out, calling vendors, calling docs, letting them know that, hey, Danny Kellison, he's approved. We're waiting on our FI. Don't send him to collections. He has an approved referral. It's approved by us. We're waiting on Blue Cross. So we're trying to reach out and remedy that. And headquarters is trying to reach out to the FI and fix that, whatever's going on. But normally it's a 1 or 2 month deal, and everything should get paid as long as we've got the bills coming in. We know what needs to be paid.
Thank you.
You're welcome.
Mike?
I've never had success with any patient who's ever been denied from Indian Health Services. I've never had one do a appeal and ever get it fixed. I mean, I never have. Everybody who's come to me who's ever appealed, I have never seen one that appeal was upheld. But the two, and I always tell them that you got to put at least 2 in. Then I get it, and then I contract health, Steve Carey, and for the most part, they do pay for it. Cherokee Nation does pay all those. Most of everything I've turned in, they have. So I don't understand the discrepancy of why one side will pay and another one won't. But in talking to some people, and maybe this was COVID stuff, but a guy tore his shoulder, another one tore his knee, and they got denied of getting it fixed. And a long time ago, I was told they had a plan, a get back to work deal. And this guy has never asked the nation for anything ever. And then the one time he gets hurt at work, he tears his shoulder, he can't get it fixed. Well, he's no longer a productive member like he's been all his life. So now he's on pain medication, and now that can open up a whole nother world. Instead of getting it fixed, we're getting them on pain medication for life if they have to keep that. I don't know if there's something that could be looked at, like the Go Back to Work program used to be, where these people have worked all their lives, we can get them fixed, put them back in their jobs. Apparently it's not like that anymore. I know things changed, it's maybe before I got on here, but these are the things that I have been told that it was in the past. So once they're denied through Indian Health Services, what's the percentage what is your percentage of helping them after they're denied, I guess is what I'm saying. Do you know how many people after they're denied, if any of them are reconsidered, other than maybe a clerical or something like that?
Well, we put the appeals in the report that I send out now, and that you've got a numerical value for those appeals that are approved and denied to come back to us.
Do you remember what that is?
I don't,
Is it in this document you just gave us?
no, it's in the one that came in.
In the
It
book?
should be in your, yes.
Yes. Is that, but that is the difference between what the Cherokee Nation money and your money, is there a difference on who can pay and who can't? I mean, do you have a different set of rules than the nation does?
There are some differences, yes.
And what are those differences?
Well, one of the things that Dr. Jones talked about last time was the alcohol in the bloodstream and the illegal drugs and being involved in a act of crime. We can't use that. We're supposed to base it solely on medical need. And like I said, the review docs go through the 300 or 400 we get every week, and we'll rank those by severity, and then they pay until they run out of money.
And I believe I talked to you like 4 years ago or close to 5, and that was probably one of the biggest reasons you ran out of money. I mean, you're allocated X amount a month, and once you run out of that, you're done, right? Unless it's something like life-threatening?
We look at our yearly budget, and before I got there, they would pay as much as they could at the beginning of the year, and at the end of the year,
Run out,
they would run out completely.
right?
We've budgeted that on a weekly budget, so that at least there's care throughout the whole year. And I'm told we're actually getting down further, paying more now than we've ever paid. We've actually gotten to the point that we can pay more than just life-threatening referrals. We can actually go out and pay some preventive things.
So from a medical standpoint, not an alcohol or drug-related deal, is there any difference between your rules and Cherokee Nation rules on what you can pay for?
Not that, other than that, not that I'm aware. I don't have Cherokee Nation rules in front of me. I'm not familiar with them, but not that I'm aware of.
Okay, thank you.
Joe?
I got a couple of questions. Is everybody back in office, or you still have remote people?
We still have some remote.
Still some remote? Second, what do we do on the emergency room? How is that treated when people rush in? Obviously, you care for them, and then you find out, what's not being paid. Is that when you send people out to go find money to pay for those people if they're in an emergency room situation?
I'm not sure if I follow you.
How do they pay for the emergency care if they're not funded under anybody in the emergency room?
Who's not, okay.
Whoever comes in, because sometimes they're hurry situations, and I know the process over there goes really quick to get them in the emergency room. Do you ever find out that some of the citizens aren't funded that are going through IHS for the care that you're providing during the emergency room?
No.
You don't?
In our emergency room? No. No,
Okay.
but
Well, that's what I was wondering, because the second thing, I just got back from Res, and they were talking about the opioid situations in a lot of emergency rooms, and there's nowhere for them to go. So it was talking about strategies after the pandemic, which we know times have changed. And have you guys looked at, like, the growth and how that's going to be handled coming to the emergency room now?
I'm not sure what Dr. Lang has talked to the Dr. Nix in the emergency room, if they've addressed that or have a plan for that.
Okay. I'd like to see a strategy, because we got a lot of people that go through there with that problem, so. But that's all I had, Chair. Thank you.
George, on the denial list, it says other denial comments eligible for Oklahoma Medicaid. So if you have first of all, do you see Medicaid patients at Clarendon?
Yes.
Okay. And Medicare, obviously. So, but if they are Medicaid patients, then they're not even considered for any kind of contract care. Is that correct?
If they have Medicaid, we are the payer of last resort, just like
Right.
Cherokee Nation. So we would require them to exhaust their Medicaid benefits before we would consider that. And normally, what I've seen is Medicaid, those vendors take Medicaid as payment in full.
Yeah. Have you, it seems like it was going through Oklahoma legislature recently that where they're considering moving Medicaid to a managed care model. How would that impact Claremore, if any? If
I don't think it would. Not
Okay.
that I've been told, no.
Okay. All right. Okay. Any other questions, Danny?
George, I got one last question. If, let's say somebody comes in the emergency room, as Joe says, and they've got a broke arm, okay? You probably don't have orthopedics that can set the arm right there at the spot. You guys meet once a week on your referrals because they're going to have to be referred out, right?
Orthopedics is pulled right off the top. If they come in, he comes in with a broke arm, his referral is taken and approved the next day and sent to the orthopedic doc to get him scheduled. Fractures and things like that can't wait.
Okay, so,
Fractures, cancer, there's a couple others, but those are the two big ones.
so they don't mail those out. They call them and set those appointments up is what they're supposed to do.
The orthopedic doc, the group we use, we send those referrals to them. They want to review that referral and the medical record that we send with it, and then they want to call the patient and set that appointment for them.
Thank you.
Any other questions for George? Thank you, George.
Thank you.
Appreciate the report, too, very much. Thank you.
And again, if you have questions, just holler at me.
Okay, thank you, George. Dr. Jones, Cherokee Nation Health Services.
Good afternoon. Thanks for having us. I want to just kind of give an overview real quick and go through a few things before we open it up for questions, if that's okay. You all have our report that you get each month, and I will highlight that, 96%, I believe, on this report was approved through contract health or purchase referred care. Our patient visits and third party continue to increase everywhere as more people are coming back to our clinics. We still find time, and we're still working through a hybrid system where we allow telemedicine when necessary, and some patients prefer telemedicine to coming in some cases. There are some cases where we can't use telemedicine, obviously, if there's labs associated or radiology or something of that nature. So, but we are still working through a hybrid model. Construction still is ongoing. I think we finally have a grand opening date for Stillwell on June the 20th. I think they've gotten the notification or starting to get that out. We've still got renovation going on at Muskogee, Nowata, Veneta, Oshaleta. And one of the things that came up recently, and for the counselors in the Nowata area, we are going to have dental services there. We've never had dental services there when we're through with this renovation or this addition. So we had some patients calling and requesting that, and we want to make sure that everybody has that knowledge because they were concerned because they were having to drive so far to Veneta or to Oshaleta. So we are going to have dental services there. Just wanted to highlight that. Salina, we're in the process of interviewing for our potential construction managers. We have hired a construction manager for the hospital project, and we're moving through technical meetings and logistics now with them. So things all are moving forward on the front of construction. Contract health issues. I want to talk about that for just briefly. We are going to offer, and I'm going to let you guys decide. You need to probably have someone coordinate it from your office that would give us 2 dates the week of June the 20th, any time that week. If you'll give us 2 different sessions, we'll accommodate you for an orientation / education. You'll get Steve Carey up front and personal, and he can give you all the ins and outs of contract health. So we just want to stay away from having a quorum, so we can break it into two dates if that would work for you guys, and you guys can discuss, let us know what works for you, and we'll accommodate that. We'll have materials there for you and have just an educational class. We can go whatever time you want to go, 1 hour to 2 hours to 3 hours. It depends on how much time you want to devote to it. So we'll be glad to do that and give you some one-on-one time. Okay? Anytime the week of June the 20th. You guys decide what 2 sessions you want to do, and we'll accommodate it.
Doc,
Yes,
I believe we have tri-council that week,
okay. We can go to the next week then.
so
Does that work for you?
that's a good week for you. When we get back from, so the 20th? Yes. Yeah. So maybe the 20th? You may look at the 20th morning and afternoon session,
June
Doc?
20th?
Yes, sir.
Okay, we might, Dr. Jones, will kind of think about June 20th, have morning and afternoon as a possibility if.
The only conflict we have on the 20th, I believe, is that, I think that's what I just said was the week, or when we're doing the grand opening for Stillwell. So
Yeah, that's,
most of us will be, I think a lot of you be there. If that doesn't conflict with you, Mr. Gary could probably work that afternoon to meet with some of you if that works out for you. But we have that on the 20th, I believe, scheduled.
Hey, Doc?
Yes.
You know, we've got a late start. Why don't we have Tara Lee work that out between us and you guys, and we will address it
great.
after.
That would be great.
work.
All right. In light of the recent events, first our thoughts and prayers go out to the families of these tragic cases of shootings that have occurred across our country in Texas and Buffalo and now in Tulsa. As a result, we've taken some steps to start to address that. We always have had active shooter training available and have done it at each one of our clinics. We had scheduled additional training in August and September of this year. I've asked Emergency Management, the Marshal Service, and our security to move up and have some tabletops at each one of our clinics over the next 2 weeks. We are increasing our security staff. We'd already put that in our budget for next year. And we're working with the Marshal Service and the AG's office and the Chief's office to allow our security personnel to be armed in the future. We're not currently an armed security. So we may be also limiting some of the access points into our clinics just for the safety of our patients and our staff. We're working through those exercises with the appropriate people to make sure that we're keeping everybody safe. We do have some, like I said, over the next 2 weeks, a lot of tabletops scheduled, and we'll be working with the staff. We'll be videoing those for those staff that aren't able to attend when law enforcement and our Marshal Service and Emergency Management are there. So I would ask that each one of you help us, because we do have from time to time patients and visitors into our clinics that aren't the easiest to deal with. So we have adopted a no tolerance policy. And anybody that has threatening behavior to our staff or to another patient, we're not going to tolerate that. And we're going to ask them to be removed, and we're going to inform the Marshal Service to be involved. You will probably be the next person that gets a call. So I appreciate in the future anything that happens like that. Please support us and be assured that we don't take these things lightly, and we're trying to protect our patients and our staff. So we're doing everything we can to move forward and give them the reassurance that they need to come and do their job in a safe place. So that's all I have for my report today, and I'll entertain any questions.
Joe?
Hey, about a year ago, we did an act renaming the Cherokee Nation Outpatient Health Center, and it was unanimously passed. So the question is, it was NOAT, which is the medicine place. Where are we on the signage and the changing of that?
So there's been some problems with getting our sign up. We had some issues with the Department of Transportation and getting that erected, and since then, those things have gone not to the way we wanted them to go. So we're relocating where that sign's going to go and getting all the text and everything appropriately put on so that you can read it. Some of the things that were suggested to us, if you look at the way our rock is and the way you put the letters on it, even though you put it up there, you can't read it. It doesn't stand out. So we're working through those issues currently. But
Okay, so when you get closer, can you just send out an email so we know where that is?
Absolutely.
That's all I had, Chair.
Thank you, Joe. Johnny?
Thank you, Mr. Chair. Hey, Dr. Jones, thank you for being here today. I just want to say, too, I truly appreciate you. You know, you returning all my phone calls, all my emails. I know I oftentimes flood your inbox, and I appreciate you hanging with me through all that. We had a discussion over email not too long ago, I believe just this past week or the week before, about at-large citizens flying in and trying to get services, healthcare services, kind of a one-stop shop, the way I read your email, from what I was explaining. I understand that we're not really staffed to do that yet, but as we move forward in the budgetary processes for this coming fiscal year, I'd like to socialize that a little bit and discuss how we can help out those citizens who are flying in from, say, Oregon or California to be able to schedule out far enough to be able to try to get as much stuff as they can in 1 week. When you sent me the patient advocacy information, that's great, and I appreciate you doing that. That's good information, which I will and also share with the rest of the council. Those are great numbers to know, great numbers to provide. But most of our folks will be coming in to go to one place, and if we could kind of brainstorm that as we go forward and talk about how we could make that a little bit easier, even if it's scheduling out 9 months, for that 90-year-old, 85-year-old who's going to fly in and try to do a few different things at once. It would be nice to be able to have a one button for them to push and one person there to kind of shepherd that instead of having them call 5 different. Instead of having that elder set in Oregon, try to juggle 5 different schedules, they can have one belly button to push. I understand that we're not there yet. I get it. But I do, as we move forward in the budgetary process, I'd really like to chat with you about it a little bit more offline and Councilwoman Coates come in on that, and then any other councilors and of course you, Chair, and talk about how we might be able to make that just a little bit easier for the people who have to come, let's say more than 700 miles away. I understand that driving is one thing, and we don't want to bump people out of line. I understand all those issues, but I'd really like to talk to you about it a little bit more in depth and see if we can't put a line item in there for maybe a run of one person to kind of work that out, and let's see how it goes. Kind of a prototype or project line item, but. That's really all I've got to say. I just wanted to socialize that with the council a little bit and where my head was at and what we were trying to work on back channel. But I appreciate you coming in today, and thank you for the information, and I'm sure we'll be in touch soon. Thanks, sir.
Very
Chair.
good.
Just to add a little bit to the security at our health clinics are kind of a magnet for our citizens. That's where a lot congregate, including family members, and had an incident at the Three Rivers in Muskogee. I happened to be there, and it was a couple of family members that bumped into each other. They didn't like each other. And it was close to escalating. And because of that, we worked out an MOA, not a cross-dep, but we have Muskogee police that would respond because our marshals, it was a 30-minute drive to get there. Well, 30 minutes is a long time, but now Three Rivers has Muskogee police. That's their phone call to Muskogee police, and they respond within minutes. Do we have that arranged with our other clinics, like in Stillwell, Wilma P? Can they call Stillwell Police, J? At Hyder, can they call J Police? So until we get further along in our security, at least we still have local authorities that can help us when we have things escalating.
We do, and we do have cross-deputization at all of our clinics, and Speaker Shambaugh can probably speak more to that than anybody.
Yeah.
So.
Okay. You want to go ahead, Mike?
Well, I know that West Siloam PD takes care of our West Siloam Casino. Anytime there's something at Sam Hyder, they call JPD first. Grove PD, Delaware County are responsible for the Grove Casino. Catoosa, I know my son had a domestic there one night, and he was in Kansas, he was in Stillwell, and Catoosa came immediately and took care of that situation. So, you know, we have good cooperation between our PDs and our sheriff's office here that do. They are probably going to be the first ones there until we get our marshal force up bigger. So, yeah, they have done a good job of helping us out.
Any other questions for Dr. Jones? Danny?
Dr. Jones, most of the questions we'll save for our little deal that when we get together, and I do appreciate that because, boy, that helps us a ton because, you know, we're kind of the boots on the ground in each one of his districts, so, you know, we get them first. If we don't know which way to go, we don't know which way to go. But is it a legal thing for when you get a referral, when you go to that doctor's office, that you have to, any amounts not paid, you're responsible for that? Is that a legal thing that has to be signed, or is that just something that office requires us to do?
And you're talking about an outside provider?
Yes, sir, like if you sent me to a nose, throat, and ear specialist, you know, and when you check in, you hand them that piece of paper, or you give them that referral from the Cherokee Nation, then they make you sign this piece of paper that says if the charges aren't taken care of, then you're responsible for them. I know Tahlequah City Health does the same thing when you have surgery. You know, then and they know that the nation is going to pay them, all right? But then they'll start dunning you, and you start getting the phone calls, and everything rolls that way. I just didn't know if that was something legal, or if that was just something that the outside entities require us to do.
Well, I think that's that's dependent on what the contracted provider is doing. It's nothing that we can do to say you're not going to be able to collect your debts if there's something that happens, because as you can appreciate, we have patients that show up at places saying Cherokee Nation will pay for it, and they've never seen our system because a lot of people misunderstand that just because they're a Cherokee citizen, they're not eligible for contract health until they go through the right process. The other thing that I do want to talk about a little bit that is misunderstood is we are the payer of last resort. So let's say if you got referred out and you had Blue Cross and Blue Shield, as George was talking about, and that insurance that you have is between you and that insurance company. Cherokee Nation has nothing to do with that. So if your insurance company needs additional information from you in order to pay that bill, we're left hanging too, because they're going to contact you, and I've had this happen to me. They contact me and said, I need this additional information on one of my kids that was seen in college. Until I fill that out, Blue Cross Blue Shield is not going to pay that bill. And until they pay that bill, Cherokee Nation's not going to pay their bill. So everybody gets pushed back because the patient hasn't responded to the information that the insurance company is requesting. Okay, does that make sense? Yes. Also, there is also a timely filing. So every entity has so much time to file for a claim to be paid. Now, some providers, some contractors are good at getting those claims out right away. Some of them sit on them maybe 30 or 60 days before they batch them and send them out. Until they're paid, we can't respond and pay because we're the payer of last resort. So there's a little bit of a built-in delay sometimes on things that we can't control because we are the last person to pay the bill. After everybody else has paid, then we pay what's left. So there are some extenuating circumstances in some of these cases that aren't as easy as black and white. Here's the service, here's paid, here everybody just lines up and pays their bill. So just want to make sure that, you know, there's a lot to it in the revenue cycle. It's a lot different, or the billing cycles, than just a black and white issue. Every case is different, depending on who the payers are, and some people have no payers, and then we do have an obligation to pay that within, and we do get those paid very quickly when there's nothing else interfering with that process.
Thank you. Mike?
Just real quick, I commend you for what you're doing to keep our people safe and keep your staff safe. Unfortunately, in these times and the way things have been happening in our country, and even other countries, my gosh, there was 50 killed in a church overseas yesterday, I believe. And even as close as Tulsa. I mean, and I think that guy was going after a specific doctor. You know, if he might have been there, he might have been the only one that he might have shot. But it's weird. I was driving here today, and on that spur, there was a sign that said 1 in every 5 people have a mental illness. 1 in 5. I mean, you start looking at that by itself. I mean, among the other things that are going on, and that's hard to defend against. So yes, it's going to be a difficult time. It is. But I think it's something that has to be done. But again, I think that, if we do need help, that the police departments and the sheriff's office will obviously respond. And George, I don't know, it's been 3 or 4 years ago, we were talking about Claremore, and there was a problem with Claremore PD coming in, or they couldn't. Has Hogner or McGirt taken care of that, where they can come in now? Because at one time, there was a problem with anybody going in there, except like the feds. I mean, was that ever fixed?
No, sir. I'm working with OGC to try to get that remedy still.
So can our marshals go there?
They were responding, they were serving us well, and the U.S. Attorney, Trent Shores,
Yes.
stopped that.
So right now, we have 0.
We have a new U.S. Attorney in Tulsa, and we are revisiting, we've set up a meeting with her to see if she would allow Cherokee Nation marshals to respond to Claremore.
Okay. All right. Would you please let us know how that goes?
I will.
All right. Thanks, sir. Thank you, Doc.
Julia?
I just wanted to, and I know that Counselor Shambaugh knows this, but I just wanted to reiterate that all of us are aware that while 20% of the population may indeed struggle with issues of mental health, that the vast, vast majority of them do not go out and pick up guns and start shooting people. So I feel like there is some stigmatization of many of us, many of our family members, many people that we know who do struggle with mental health issues, and that we are careful not to say that that is the reason that this gun violence is happening, because it isn't, in my opinion. Thank you.
Any other questions for Dr. Jones? I see none. I might have Dr. Montgomery come in. I just want to ask a couple of medication questions.
Absolutely.
Thank you, Dr. Jones.
Thank you.
Welcome, Dr. Montgomery.
Hello, everyone.
Any opening remarks?
No.
Okay, all right. I try to attend the medical executive meeting every month. I noticed a new therapeutic, Paxlovid. Could you kind of explain to the council kind of
Sure.
what that does and doesn't do?
Paxlovid is an oral pill form of medication used to treat acute COVID infection. Most of us know what Tamiflu is to treat influenza. Well, Paxlovid is an acute treatment for COVID infection for people 12 years of age and older that weigh more than 40 kilograms, who are at risk for disease progression, but are not so sick that they need to be in the hospital. The treatment needs to be initiated within the first 5 days of symptom onset. If you wait beyond 5 days, it's probably not going to be quite as effective. And again, it's a pill form medication you take twice a day for 5 days. Now, your doctor may, or your provider may want you to come in and be assessed just to see how sick you are, to make sure that you're not too sick, believe it or not. But they may assess you, they may want to check your oxygen level before they decide to prescribe this medication for you. But it's very easy, very convenient. There's one other important thing to mention, though. It does have significant drug-to-drug interactions. And there are a lot of very common medications that you have to be very careful about using it with. Medicines like statins, which many people take, many adults. You can stop taking the statin briefly, but your doctor, your provider needs to review that with you so that you know not to take certain medications along with this. Is that a fairly good description?
Sure.
Answer any questions about it?
So
Well, I should add, it's available in all of our clinics, and again, if you do a test at home that tests positive, your provider may say, well, I want you to come in for a confirmatory test in the clinic before I prescribe it. They may know you well and know that your home test is going to be accurate and reliable, and they may be willing to prescribe it for you without repeating a test, but just know, be flexible with your provider. They want to help you. You help them make that decision to whether to treat you or not.
So an in-office visit is necessary to receive it, or?
Again, it's recommended, but again, some doctors may know you so well, they may know what medications you're on, they may be able to assess you over the phone and determine you're not that sick, so sick that it wouldn't work well, and again, they may be willing to prescribe it for you with a phone visit.
Great. Any other question for Dr. Montgomery? Before I let you go, Dr. Montgomery, we mentioned about medications after surgery, opioid therapy. Do we have a standard how long we prescribe for patients that are recovering from surgery? Do we have like that window that we prescribe opiates and then?
We do, and that was established by the state of Oklahoma a couple of years ago when they really, for lack of a better word, they put the brakes on opioid prescribing. But there is a window for postoperative treatment with opioids. You can get, I believe, 7 days in a renewal, but then beyond that, you're going to need to see your provider before you'll be able to be renewed with more medication. Is that helpful?
Sure. So in other words, 2 weeks is about as long normally?
Normally.
That we will
yes.
prescribe
Under normal
opiates
circumstances,
for.
yes.
And I guess in the Tulsa incident, the patient was, according to press releases, was upset because he was still having pain. But he was certainly within the window. I'm sure he had opiates at home to take, but who knows what happened there.
Yeah.
Danny?
So, Dr. Montgomery, with that said, back surgeries, a lot of different things. Is the nation looking at any progressive treatment that you may be able to go instead of the opioids? Because Lyrica, gabapentin, all of those things are given to patients that, you know, that are having this pain. How, especially with our opioid, the chief and us signing the legislature to try to cut this back, how are we going to treat people that are having this type of pain like this gentleman says that he had and as we go forward?
Tough question to answer. Again, I think any patient that undergoes an operation where there's going to be postoperative pain, that doctor that performs the surgery should have a treatment plan that incorporates more than just prescribing of opioids, be it physical therapy or even some alternative therapies. Mr. Counselor, I think the other concern you might be expressing is that patient that has chronic pain. That is a very challenging diagnosis, and there are doctors who specialize in that assist our providers with that, assist patients with that, but it generally is best approached with a combination of physical therapy. If opiates are appropriate and have been used for a long period of time, they need to be looked at and viewed regularly, and that's required by the law, by the way. You have to reassess a person's opioid use and always try to taper it if possible and reassess their response to treatment. I hope that answered your question.
Any other questions for Dr. Montgomery? Thank you, Dr. Montgomery.
Thank you all.
Appreciate you coming.
Yes.
All right, Lisa, Public Health. Lisa Pivek and is here today. You've got the floor.
All right, thank you so much. Good afternoon. Thank you for allowing us to be here today to talk a little bit about public health and our Public Health May report. I want to thank Dr. Jones and Dr. Montgomery for their health services report. They are extremely important partners with public health. We work to make sure that and hope that patients that are coming through the door are healthier when they come in, and much of our work is in communities and outside of the clinical walls, but their job is so important to us, and we are good partners, and we appreciate them as much as any other partner we have. We're really excited to work closely with them. We have just completed the tribal health assessment. Here's a printed copy of the tribal health assessment. It should be located on our website within a few days, that CherokeePublicHealth.org. This particular tribal health assessment covers health conditions, but it also covers all of those things that contribute to the health status of an individual, such as housing and education, poverty levels, clean environment, areas of that nature that you can look at. And it helps us to develop plans not only internally but externally. We're working on a tribal health improvement plan, which is outward facing into the community and requires community input. We're also working, have finished a strategic plan, which is us looking internally at what we need to do to improve our public health systems as we move forward. It's a very informative document. It does have community input, a community survey, stakeholder partners, and we really want to thank all of the other groups that worked with us, including environmental services and education, language and culture, were big pieces of putting this together. It's really a good document. It outlined a lot of things that we need to work on. It identifies issues where we need to put our resources, and it also identifies those issues internally that we need to work on, one of which is to collecting more primary data for public health, including Cherokee-specific data and data in communities, more qualitative data. Qualitative data is that data that encompasses people's opinions and thoughts and knowledge about particular issues. So it's a great document. I encourage you to take a look at it. We will have some printed copies in the next month or so that we can distribute. We're trying to be as green as possible and keep as much online as we can and not print as many, but we will have a few copies available for sure. That leads us to also working on our performance management plan, which is also internal facing that we're working on right now. The cross-collaborative is really important as it relates to this the tribal health assessment. That's our work with other divisions across the tribe, looking at those conditions that impact your health or that lay out what your health status looks like. 80% of your health is shaped outside of other areas outside of inside your community. 80% of your health depends on where you live, what resources are available to you, your income level, education, a whole lot of things that impact your health every day are important in public health, and our job is to convene all partners and work towards collective solutions on how to improve the health status of the entire community. It's working to give everyone in the communities a chance to thrive and provide those conditions for everyone to thrive. We're really excited about our ability to work with those groups. Language and culture is also helping us provide the foundation, and they're included in all of our meetings and in our fundamental philosophies for working with communities and also developing all of our improvement plans. If you notice on the CDC was scheduled to be here the 24th, and they did indeed come, a team to plan for the meeting that's going to happen August 3rd and 4th here at Chota Center. So I encourage you, if you have time during the 3rd and 4th, to seek out some more information about their visit. It's a federal visit. There'll be many people here from other tribes, persons from centers, institutes, and offices at CDC. So it encompasses a great deal of people there. You might notice that the WIC numbers were only for through the 18th. If they even appeared on here, we were having a little bit of trouble getting those on this particular one. The WIC is really busy with, as you might remember, the formula recall and the formula shortage situation. As Brenda Carter, who has been here a long time, has been WIC director for many, many, many years, decades, said it's the most serious challenge that she's had to deal with since she's been here in WIC, is this shortage of formula. But they're working closely with WIC patients. I know they also work with any person that calls them to try to help them find formula. They have a shipment of a couple of pallets of formula, and they're also working to get information out to community members. I know that some of the WIC staff actually help individual patients and drive formula to them. If they find the formula they need and drive it to them. They are been told by USDA that they're going to see, it will be July, late July, before stores start to see an impact, a stock on the shelf. But they also urge them to consider that it may be August or later before they actually see that make a big difference. And they're still doing summer EBTC with children. They're still getting those cards out, and they're dealing with lots of phone calls and making sure that everyone has the correct PIN number, or they haven't lost their card, or if they make sure they received it in the mail, and any other questions that might go with SEBTC. You can take a look at our WINGS numbers, our in-person running, people joining in person are continuing to increase. The May run, we had 916 participants, but 338 in person. So that's an increase up from a couple of months before. So we're starting to see more people come out and work out in communities and feel safe coming to the runs. And we're really going to keep the virtual option as well, because we see that working very well with citizens across the Cherokee Nation. I think that is all I have on the report, and I'm happy to entertain questions.
Joe, go ahead.
Do you still have the WIC office at 6th and Peoria?
It is in the Indian Healthcare Resource Center, yes.
Is it still there?
Yes, it is.
Okay, I've been asked about that, because there's no sign out front or anything that shows them where to go.
Yeah, that may be a site-specific issue for that particular one, but yes, we do have offices inside of Indian Healthcare Resource Center.
All right, thank you.
So do we have an instance, Lisa, where we have a parent, mom come in needing formula, and we don't, have we had an instance where we just flat out don't have any?
You know, would have to ask Brenda from WIC about that specifically, but she hasn't noted any specific to me. Most of them, they can find the formula. I would say the majority, they have had to find it. It might take a little bit, and it may have to travel, but I don't know for sure how many. I know, for what I do know has happened is that WIC participants have reported to the emergency room at Hastings without needing formula, and the emergency room was absolutely fantastic at handling that, and we've met with staff to make sure that they have some excess formula right there that they can distribute for those parents when that happens.
Is there a healthy substitute for formula?
You know, the USDA, the CDC, the National Institutes of Health don't have a recommendation for any other but FDA-approved formulas.
Okay.
Yes.
Any other questions for Lisa? Today, Lisa, at our event with the Celebrate Women Man Killers event, there was a mask policy. Was that driven by new data, just the fact that we were enclosed indoors with a lot of people? Because that's the first time I've seen a mask incorporate again now after a period of time where we didn't have masks.
Dr. Gann isn't here today.
Uh-huh.
Ross Ogden is in his place, and he can answer some of that question. But I would say that those policies are formed in close collaboration between Dr. Montgomery and Dr. Gann and health leadership in deciding what the best option is for our patients and for our staff and to keep everyone healthy. Is Dr. Montgomery gone, or is he still here? I think he took off. But I'll have Ross address that question in just a second when he gets up.
Okay, great.
Yeah.
Any other questions for Lisa? So Ross is on the spot.
He is. And thank you, guys, for having us today. We appreciate your support, and we look forward to working with you further.
Thank you, Lisa.
Ross Ogden is an epidemiologist with the Public Health Department. I'll have him step up. He was a big contributor and one of the main authors for the tribal health assessment as well.
Okay.
So.
Welcome, Ross.
Thank you. It's an honor to be here. So, not much is changing with COVID, drastically speaking. We're having a gradual increase in cases. I call it the COVID creep, trademark pending. It's slowly going up. But on the flip side of that, hospitalizations and daily rate of deaths are both down. So, as far as masking, Chief is constantly reviewing guidance and felt that it was best for that situation for the safety of the elders and those people present at that particular event.
Just this particular event, given the number of people, and we had a lot of elders there, including myself.
Sorry, if you don't mind, I'll step in here.
Okay, Terry Lee.
Sorry. Thank you for recognizing me to speak. Chief Hoskin is just constantly reviewing the safety measures as well as the types of events, whether we're going to have them indoors, the number of people that we have there present. And so you may see, as numbers kind of continue, a change in what we do. And today was one of those examples, just due to the number of elders present. We want to be respectful for all of those people. And so we require our administration staff to mask when we're in the presence of others, just out of respect. And we also today chose to mask for safety reasons, just to make sure that we were doing everything we could do to host the best possible event. in memory of Miss Wilma. So you may see that again in the future as we continue to move through some of our larger scale events. If we're indoors, we will observe masking when we can and when we feel that it's appropriate. And when we're outdoors, we'll do a little bit more of a relaxed approach. But I'm happy to take any further questions on that.
Sean?
Yeah, I was just thinking when I was leaving, that went so smooth, whoever was responsible for that, and I'm sure there's a lot of people. But,
Yes, sir.
wow, from the golf carts and the lines and the foods and the signage, the parking lot attendants, it was a smooth little thing. So
Thank you.
kudos to whoever did that.
Thank you. I wish I could take credit for it, but we have a fantastic team, our government relations team, my team, including Cameron and several others. They did really well today.
Any other questions for Tara Lee? I see none. Thank you, Tara
Thank
Lee.
you.
Okay, moving on from reports to old business, none. New business, none pending. Announcements? Any announcements? Johnny?
Mr. Chair, if you were going to mention this, I apologize for stepping on your toes. I can easily back down, but I just want to remind everybody of the Innovative Readiness Training, Health Mission 2022 kicking off this week. This, for the next 2 weeks, free medical and dental exams at the Sequoia Gym. First come, first serve, adults only, no questions asked. Go in there, get all kinds of services, and they won't, tribal affiliation doesn't matter. First come, first serve, adults only. Just please spread the word as much as you can. I know there's a lot of people who could be seen over there, and they do great work. Mr. Chair.
Thank you, Johnny. Okay, I might mention too, in the announcement part of it, with Dora, the Nowata Dental Clinic is going to be a 2-doctor clinic and 2 hygienists. We tried the 1-doctor model at Oshaleta, and that doesn't work in terms of access, so that's why we're moving directly to a 2-doctor clinic in Nowata. Okay, I need one more motion. Second, I assume. All those in favor? We are adjourned.